Hello everyone, a warm welcome from the Australian National University here in Canberra, Australia. I hope that you and your loved ones are keeping safe and healthy. Before I go on any further, I would like to acknowledge the Ngunnawal and Ngambri people who are the traditional owners of the land where ANU is located. And this is where we will be broadcasting to you from. I want to pay my respects to the elders, past, present, and emerging. And I acknowledge that this land will always be the land of the Aboriginal and Torres Strait Islander peoples. Now, as always, we are very pleased to welcome our attendees from various parts of Australia as well as around the globe. In the past, we have had audience tuning in from places like India, China, Burma, and Fiji, South Africa, just to name a few. I want to start off by sharing a quote I stumbled across earlier this week. And this quote is by Robert Noyce, who is an American entrepreneur. He says that knowledge is power, and when knowledge is shared, power is multiplied. And I think this is a very powerful statement, and it really explains a lot of why we're doing this every week. Through our weekly webinar series, we really hope to be able to use this platform to exchange our skills and expertise to help one another during the pandemic. Many of us have tuned in to listen to the talk entitled COVID-19, Home-Based Care and Monitoring. But before I introduce our wonderful presenter and his panelists, I just want to talk a little bit about our team and introduce myself. So I am Evangeline. I'm one of the medical students and a volunteer for the ANU COVID-19 Peer Support Program. And joining me are my colleagues. So we have Bridget Nielsen, who is also another medical student volunteer. And we're led by Dipti Talalika, who is an associate professor in hematology. And she has been leading this peer support program for the last couple of months. Now, you will notice that all of our attendees have their videos and microphones switched off. This is just to make sure that our sound quality is optimal and there won't be any interruptions during the recording. In saying that, we do encourage our attendees to interact with us, and you can do so by using the Q&A button that's located at the bottom of your screen. And if you wish, there is an option to submit your questions or input anonymously. If there are any issues, I'll invite you to please email us at this email address, that is international.health@anu.edu.anu. Please note that we will also be launching a poll towards the end of the presentation, and I'll invite all of our audience to please select a response. And lastly, please note that this talk is being recorded. So going on to today's webinar, as I said, it is entitled COVID-19 Home-Based Care and Monitoring, and this will be delivered by additional Professor Neeraj Nishal. He is an internal medicine physician and has been working in All India Institute of Medical Sciences in New Delhi. He has a special interest in infectious diseases, and since early 2020, last year, he has been working at the forefront of COVID, working on patient management and resource development for the country. Joining him today will be a panelist, Associate Professor Animesh Ray. He also works at the All India Institute of Medical Sciences, and he is a respiratory physician by training and is actively involved in patient services and research in pulmonology, critical care, and sleep medicine. Now, as you can tell, we have very esteemed speakers with us tonight. So without further delay, I'd like to hand over to you, Dr.
Should I start now?
Yes, please.
Yeah. So good evening, everyone, and good morning to places where it's still morning, and good afternoon to places where it's still afternoon. So thank you very much for inviting me. We all have been grappling with this pandemic for almost now 2 years now. And in some places, it seems things are under control, but at some places, still the cases are on rise. So there's a lot of controversy, lot of you can say we are still grappling with the exact nature of this disease, how it's going to behave, how it should be controlled, what sort of vaccine will be the best to control this pandemic, what precautions should continue, which precaution can be lifted, how should we go about the lockdown stuff. So these all are still developing. So you can very well understand the situation which we are in right now and what type of problem this COVID-19 has created for each one of us. So it's, I will say it's for researcher, it's a lifetime experience when you have seen a new disease which has created havoc across the globe, to show your skills, to show your research abilities to find a solution to this particular problem. So over last 2 years, whatever we have learned about this disease, how to control and manage this disease. So one part of which is home-based care in such patients. That is what I will be covering. And I will just start sharing my screen with the permission of the organizers. So I hope my screen is visible now.
Yes, it is.
Yeah. So before I start, I would like to start with saying that this is something which we all should know, that guidelines are not guidelines, but only good lines. And they may act as a guiding principle. But clinical care should reflect the patient values, preferences, and experience of the treating physician, especially the disease like COVID-19, which is relatively new disease. One cannot expect to have a vast evidence right at the start of the pandemic. So whatever we did on whatever we are doing is based on our understanding about this disease as this disease has been unfolding in front of us. So all evidence is subject to change. What may be standard of care today may prove to be futile in the future. For an example, I have been associated with the dissemination about this disease, the information, the awareness among people. So at the start of the pandemic, we used to say not everybody needs mask. If today I say not everybody needs a mask, then everybody thinks this fellow even does not know that mask is essential to prevent the spread of this infection. But at that time, since it was still an exotic disease, not prevalent in India, and this shortage of masks could have happened if everybody would have started using masks without any reason. So at that time, the best thing was not to, everybody did not require masks, that information should have been disseminated, and that's what we did. But as this become more of, I say, once we have community transmission and everything, then we had to use masks. So the principle changed, and now and after that we started saying, okay, no, everybody needs a mask. So with this example, I will say whatever information we are gathering, this is still evolving, and what we are talking about today may not be true tomorrow. So these all will change, and of course I declare no conflict of interest for this talk. So we all know this COVID-19 stands for coronavirus disease 2019, and the causative organism for this particular disease is a SARS-CoV-2 virus. So this coronavirus is known to cause outbreaks in previous times as well. So the most common being the SARS and MERS, which we saw in early 2000. But luckily they remained localized and did not attain a pandemic situation. But this COVID-19 did what we always have been fearing, that some virus outbreak may happen that may take a pandemic scenario. And that's what has happened with COVID-19. So the origin is still controversy, but this disease came into prominence when a large number of cases were reported from Hubei province, China in December 2019. From there, it spread to other part of the world. That is what is the current theory at the moment. COVID-19 have symptoms which is similar to any other viral illness like fever, cough, tiredness, and well-described loss of taste or smell. Many other diseases can also cause loss of taste or smell, but the peculiar thing about this particular disease is that loss of smell will be a complete loss of smell at one go. In other scenario, usually it's a partial loss of smell. So if you develop a sudden loss of smell completely, then there is very high chances that you might be having this particular infection, especially if there are reported cases in your community. So in fact, this has been taken as a surrogate marker of COVID-19 in appropriate settings. Other common symptoms include sore throat, headache, body aches, patient may have diarrhea, patient may develop rash, patient may develop red or irritated eyes, which we call as conjunctivitis. What is important to note that more than 80% of cases are asymptomatic and are detected as a consequence of contact tracing, screening for any other reasons, like say if somebody is planned for surgery or something of that sort. So these are picked incidentally. The problem with this, though it's good for a clinician that these patients are usually asymptomatic, but if you look as from pandemic perspective, then these asymptomatic cases may actually be a very efficient source of spread of this particular infection. And that's why this acquired a pandemic proportion before we realized, because most of cases were asymptomatic and inadvertently they continued transmitting this infection to others in their family, in their communities, their workplace, their schools, everywhere. Those who are symptomatic, the symptoms may vary, could be constellation of symptoms, simple single symptoms, or as the disease progresses, they may develop further symptoms depending on what organ system have been involved apart from respiratory symptoms. So what started as a viral respiratory illness is now believed to not just limited to lungs, but can cause myriad of symptoms depending on the symptoms system involved, whether it's neurological system or renal system, hepatic system, GI symptom, cardiac, various thromboembolic complications, endocrine system can be involved, various dermatological manifestations have been described. So this is mainly related to the ACE2 receptors, which are the receptor for entry of this virus in our body, which are widely distributed. So whichever organ has ACE2 receptors, this virus can invade those organs and cause symptoms based on the system involvement. Mode of transmission, initially contact transmission was something, contact and droplet transmission was something which was emphasized upon. But as the data gathered further, as the disease, the pandemic progressed, it was realized that airborne transmission of smaller droplets and particles that are suspended over longer distance and time are also important mode of transmission of this particular disease. So this led to this very important understanding why the people staying in a closed environment get infected even if there is a single person who is infected in that particular setting. So now, as we started, contact and droplet transmission was thought to be the main way of transmission, but now airborne transmission is very important. So initial transmission mode, when somebody cough or sneezes who is infected, releases infected droplets. With contaminated hand, if he can transmit it to someone else's, if you shake hand with that particular person, if you're touching a surface which is touched by other people, you can transmit this infection accordingly. So it's a very, this virus is very infectious. Even low number of virus particle is sufficient to infect a person. And that's why it spreads so easily. So when you infected person cough or sneezes, then this droplet usually travel less than 1 meter. So if you are maintaining a distance of 1 meter from such person, then definitely you are not going to get infected with droplets. However, this aerosol formation can actually infect person beyond 1 meter as well. That's why if you are infected, you should isolate yourself and keep yourself in a and in case if you are meeting with other people, preferably meet in a well-ventilated place. Best thing would be to meet outdoors. So this is just explaining the same thing. So when to suspect a patient may have a COVID-19 disease? So the clinical criteria include acute onset fever and cough, or acute onset of 3 or more of the following symptoms, including fever, cough, weakness or fatigue, headache, myalgia, sore throat and coryza, dyspnea. Patient may have anorexia, nausea, vomiting, diarrhea, or any alteration in mental status. So these patients should be suspected in appropriate clinical settings. Epidemiological criteria include any one of the following applies within 14 days prior to symptom onset. That is, a person residing or working in an area with high transmission risk, residing or traveling to area with community transmission, or working in any healthcare settings. If a person has acute respiratory illness with history of fever, which is more than 38 degrees centigrade, has cough, onset within last 10 days, and patient is requiring hospitalization, all these people should be considered a suspected case of COVID-19 in present scenario. So we say probable case when they have clinical criteria or they have contact of a probable or confirmed cases linked to a COVID-19 cluster, or they have a suspect COVID-19 chest imaging, which is suggestive of COVID-19, have recent onset loss of smell or loss of taste, absence of other identified causes which can explain this loss of taste or smell, death which is not otherwise explained, which has respiratory distress preceding death, contact of probable or confirmed case or linked to a COVID-19 cluster. These all should be considered as probable case. Confirmed case when you confirm it with positive nucleotide amplification test or RT-PCR. Suspect or probable case who has tested positive with rapid antigen test, or asymptomatic contact of probable or confirmed case who have tested positive with your routine RT-PCR or rapid antigen test. So all these patients are said to be confirmed cases of COVID-19. So when you suspect a COVID-19 patient, you should test that patient for SARS-CoV-2. So if it's negative, you observe that patient, retest if symptoms or fever persist or shortness of breath worsens. If this happens, then you retest that person depending on whether it tests negative. If he's negative, then he is negative. If he turns positive, then you will have to classify him as either moderate or severe. These group of patients will require hospital admission. And if patient is labeled as mild, then based on depending on the situation, one can opt for home isolation in such cases. So when we define how we define mild COVID-19? So uncomplicated URTI with mild symptoms like fever, cough, sore throat, coryza, malaise, headache, etc., without any shortness of breath or hypoxia. Moderate COVID-19 when there is evidence of pneumonia in the form of onset of dyspnea, hypoxia along with fever and cough. If the saturation on room air is between 90 to 93% and respiratory rate is more than 24 per minute. And this will exclude those who have signs of severe disease. When we say severe disease, then severe pneumonia patients usually have one or more of the following symptoms, that is respiratory rate of more than 30 minutes, severe respiratory distress, or room air saturation of less than 90%. Patient is said to be in ARDS when worsening of respiratory symptoms happen within 1 week of known clinical insult, and chest imaging will show feature of ARDS in form of bilateral opacities, respiratory failures which cannot be explained by cardiac failure, and if we see oxygenation impairment, one can divide it into mild, moderate, or severe ARDS based on the PF ratio values. However, it's important to note that most of these guidelines which classify severity of COVID-19 does not only include pulmonary symptoms. They do not include life-threatening extrapulmonary manifestation of this particular disease. So if somebody has any life-threatening extrapulmonary manifestation in form of, say, cardiomyopathy, say stroke, or any other insult which can be life-threatening, these patients should be advised even if their respiratory compromise is not there. So we have to take a clinical judgment which patient actually can be asked for home isolation and which patients require hospitalization. So when we home isolation should be advised only after proper evaluation by a medical officer. So if a person is more than 60 years, hypertensive, diabetes, have some heart disease, underlying heart disease, chronic lung disease or liver or kidney disease, have prior history of cerebrovascular disease, or if the patient is immunocompromised because of, say, whether he is HIV positive, is a transplant recipient, is on cancer therapy, these patients should be advised, even if they have mild disease, for home isolation after proper evaluation by treating medical officer, not without that. So deciding on home based care, the prerequisite include the patient should be stable enough to receive care at home, that is mild disease. Appropriate caregivers should be available at home to provide care on 24/7 basis with regular communication with the hospital. There should be a bedroom where the patient can recover without sharing immediate space with others. That's also very important. There should preferably a separate bathroom for the patient. If this is not feasible, care should be taken to disinfect the bathroom after each use. In that case, like said, aerosol generation is important method of transmission. So if the bathroom has exhaust fan, that would be very important. Resource for access to food and other necessities should be available. Patients and other household members can adhere to precautions recommended as part of home care or isolation, so that the infection does not spread to other household members. Once you get your contacts ready, if we are going for home isolation, all health information and care, your doctor, your health facilities, the nearest health center, hotline or emergency numbers should be ready with you. You should form a support network of your family, friends, neighbors, if you are a student at school or work, so that all the necessary arrangement can be done without you stepping out of the house with their help. Stock up on supplies with regular medicines. So if you have some comorbidities, you should be stocking up medication for that, medical mask, cleaner and disinfectants. Prepare a separate room or isolated space and keep distance from others. Put in place again the support network for your daily necessities like groceries, any transport or childcare which may be required if you have small kids in your family, and other essential services. Ideally, the room should be well ventilated. If possible, natural ventilation should be there. If possible, open windows frequently. Identify one household member to be the contact person who is not at high risk. He should not be having any comorbidities, putting him on extra risk if he contracts this infection. So that is very important. So you have to select one family members without comorbidities. He should be wearing a medical mask if going into the room of the sick person. Use separate dishes, cups, eating utensils, and beddings from the sick person. Do not share all these important articles. And clean and disinfect frequently touched surfaces, especially in the areas where the patient may have moved around. Monitor the sick person's symptoms regularly. Pay special attention if the person is at high risk for any serious illnesses like elderly people, people with comorbidities. Ensure the patient gets adequate rest. That is very important. What we have realized over the time, that rest is very essential if you want to recover from this particular illness. And similarly, it's important that you stay hydrated. So hydration and rest is very important, especially for those patients who have mild form of disease. Frequent hand washing with soap and water, or with alcohol-based sanitizer, that is important. You have to follow cough etiquettes. Do not share personal items. Clean frequently touched surfaces like, say, doorknobs, with preferably with 1% hypochlorite solution if you have some sick person in your house. Always use a triple layer medical mask in that particular house. Wherever feasible, use N95 mask. You have to discard your mask after 8 hours of use, or in case if it is wet or visibly soiled, you have to discard it earlier. Both caregivers and patients should wear preferably a N95 mask when they are in the same room. Say if you are going to give him some say food items, or you're going to check for his symptoms, then you should be wearing a 95 mask along with the patient as well. Mask should be discarded in paper bags only after disinfecting it with 1% sodium hypochlorite solution. And once you discard this mask, then always perform hand hygiene. Whenever you touch any contaminated thing, you have to perform hand hygiene. That is very important to prevent spread of infection in your household. One of the most intriguing and most difficult thing is to explain the patient how to use a pulse oximeter, because this oxygen level is something which is the cornerstone of management of such patients. So if not taken properly, it may cause panic and false alarm. And if not taken properly, it can also miss the severity of the disease the patient might have progressed to. So do not panic while monitoring your oxygen saturation. Always test using one reliable finger pulse oximeter. Do not keep on changing your pulse oximeter, but at the same time, please ensure that you keep changing the battery of the pulse oximeter at frequent, regular intervals. So if you have any nail polish or falseness, especially for females, then you should remove that before checking your oxygen saturation. And if your hands are cold, please always rub your hands to make it warm and then take oxygen saturation, because if your hands are cold, this blood supply to your periphery may not be good, and these pulse oximeter, which is based on the flow of blood in the extremities, your fingers, may erroneously show low oxygen saturation, which may cause unnecessary panic. Make sure you have been resting for at least 5 minutes before taking your measurement. Rest your hand on your chest at heart levels and hold still. If you keep on moving your hands while taking the saturation, then the saturation may be false because the sensor may not be working properly. Switch the pulse oximeter on and place it on your finger. Reading takes time to steady, so keep the pulse oximeter in place for at least a minute or longer if the reading keeps changing. So if once the reading stabilizes, then that is mostly the correct reading. Record the highest result once the reading has not changed for 5 seconds. So if you take these all precautions, then you will be able to take proper oxygen saturation and without carrying unnecessary panicky situation. So the patient has to stay in communication with treating physician and promptly report any deterioration or onset of new symptoms. If you have comorbidities, you have to continue medications for comorbid condition and in consultation with your physician. Symptomatic treatment in form of saline gargle and steam inhalation may help in soothing your sore throat or blocked nose. But this should not be thought as a treatment for COVID-19, because if you see, there were a lot of social media, I will say, information claiming that the steam inhalation will kill the virus's nasal cavity. If you keep on doing gargles, it's going to kill virus in your throat, and was promoted as a preventive therapy. So to best of our understanding, these saline gargles and steam inhalation are only symptomatic treatment. These are not going to kill the virus, or this is not going to prevent you from acquiring infection. So these two methods are mainly for symptomatic relief of blocked nose or sore throat. For fever, one can take paracetamol 4 to 5 times as the need be. If fever is persisting, not coming down on paracetamol, one can consider taking NSAIDs like tablet naproxen, which we prescribe in our settings. But at the same time, you have to consult a physician if you are considering taking naproxen. For other symptomatic treatment like running nose, one can use tablet cetirizine. For cough, any antitussive can be taken. If fever persists for more than 5 to 7 days, one may consider taking inhaled budesonide. We, in our guidelines, have suggested use of inhalation budesonide on the available evidence, primarily one trial from UK. So if fever persists and cough persists beyond 5 days, one may consider taking inhaled budesonide because of its local anti-inflammatory effect. But before taking anything, you have to consult your physician. We do not routinely prescribe oral steroid in home care setting. If fever is persisting beyond 7 days, cough is worsening, you have to consult your physician. If saturation is coming down, you may be required to be in hospital rather than staying at home. Remdesivir or any other investigational therapy should not be procured and administered at home. Decision is to be taken after careful consideration by physician in a hospital setting. You have to take immediate medical advice for hospital admission in case if you have difficulty in breathing, if there is dip in saturation, if there is persistent pain, pressure in the chest, if there is mental confusion or inability to arouse, especially in elderly people, or any symptom which you feel is not right, which was not there and is progressing. So one can have a chart of various symptoms, record this chart at least 3 times a day, the important being pulse, oxygen level, temperature, if the patient is feeling better or the same, how is the breathing pattern, is it same, is it progressing? So these all charts should be made and should be shared with your physician in which to whom you are in touch with. So these chart will help in early identification in case if your patient is deteriorating, so that adequate measures can be taken if required, that hospital admission can be taken. So this is the important message which one should have for any patient who have opted for home isolation or home-based care. When to discontinue home isolation? So at least 10 days having passed from the onset of symptoms, and at least the patient is afebrile for 3 days. There is no need for test of cure after the home isolation period is over. So that is again important because RT-PCR can remain positive for many days at long, and it only denotes the shedding of the already dead virus. So we usually do not prescribe repeat RT-PCR at the time of discharge or at the end of home isolation. Other measures include you have to ensure that you continue following your hand hygiene methods. You have to clean your house properly, especially the frequently touched surfaces. If you show symptoms of COVID-19, you have to self-isolate, should wear mask, especially when other people are around you, and seek medical advice. Do not treat yourself. If any member of your household shows symptoms of COVID-19, seek medical advice and follow your local health authority guidance. Stay positive. Always avoid alarmist news. Be connected to friends and family. You should have a hobby, especially during lockdown when your movement is restricted, when you are not able to meet your friends physically. You have to stay physically fit. You should exercise regularly, eat a nutritious diet, and wherever possible, do not smoke, because that reduces your lung capacity, increases your vulnerability to respiratory infection. So if you are a smoker, preferably quit smoking. Waste management is also important. If a person is in household is positive, then all waste should be collected in bags, securely tied, and handed over to municipal solid waste collector as per rule and regulation if your local urban bodies for final disposal. General waste should not be stored in yellow bags. Only the used masks, gloves, tissues, or swabs contaminated with body fluids, blood of COVID-19 patients, including syringes, medicine, etc., if they are generated, should be treated as biomedical waste. Biomedical waste should be collected separately in yellow bags provided by your urban local bodies. These bags can be placed in separate and dedicated dustbins of appropriate size. One of the most important thing is COVID infodemic. So avoid any misinformation about COVID-19 in social media. Always gather information from official sources. If you see COVID-19 misinformation, especially on social media, please do not engage. Please do not reply or share or quote misinformation, because this spread faster than the virus itself. Message privately to that person that whatever they have forwarded, it is misleading, it's not correct information. If they don't listen to you, you can block them, you can report them. Instead of spreading misinformation, always spread official advice. Because we have seen that the fake news travel faster than real news. So that's important. That's why it's important that we serve as a blockage to such information. So we have to be a barrier and not carrier to this information pandemic. That is something which we have to contribute to stop this spread of this infodemic. So if you are COVID positive, don't panic, be positive in spirit, just not positive for RT-PCR. Home care is advisable in asymptomatic and mild COVID patient especially without comorbidities. Keep essential over-the-counter medicines, but do not hold medical supplies. Help to break the chain by social distancing, mask, hand washing, vaccination. Create and participate in self-help groups because these are very tough times, both mentally, socially, economically, health-wise. So we have to help each other in these tiring times. Ignorance is not bliss anymore. So be aware of infodemic. Please be barrier to this information pandemic. Thank you.
Thank you very much, Dr. Nishal. That was an amazing talk and very, very practical as well. I really enjoyed it. Now, in the audience, if there are any questions or input that you want to ask our presenter and our panelists, I'll get you to start popping them on the Q&A chat. In the meantime, I'll get one of our members to launch a poll. And I'll invite everyone to select the most appropriate response. And when you're ready, we can start our Q&A session.
Again, thank you so much, Dr. Niraj. That was a fantastic talk and yeah, very informative for all of us, learning about managing COVID and patient care at home. We do have a number of questions that have been posed during the talk. And again, if anybody has more questions, please feel free to submit them. But I might just start with our first question, which is how frequently should suspected patients be tested? So is it just once or is it on subsequent days during home isolation?
So Dr. Nimesh, would you like to take that question, please?
Yeah, sure. Thank you, Niraj. So if I understand, this question is about the frequency of testing of suspects. So, so the guidelines differ from country to country, but the usual norm as suggested by CDC, and which is also being followed in our country, is that whenever there is a contact, patient has symptoms, you should test the patient, you should test subject that patient to test. If the RT-PCR or any test which you're using it is negative, then you repeat the test after a finite period, which is usually between 5 to 7 days. So that's for symptomatic patients. For asymptomatic patient, again, as soon as the patient has a contact, we tell the patient to undergo a test, and then we tell them to monitor symptoms. If the patient continues to remain asymptomatic after the contact, again, after 5 to 7 days, the test may be repeated. Now, this again comes from the incubation period of COVID-19. We know that the incubation period varies between 1 to 14 days, with a median of around, say, 5 to 6 days. Right? So, based on this, we test once, initial contact, and then we repeat it, say, after 5 to 7 days.
Thank you, Dr. Animesh. And another question that is closely related is, would you recommend that household members get tested too, just in case?
Yeah, so invariably what happens is when a person tests positive, that the household members also report close contact before the test comes positive. So in these cases, the household members, they have had close contacts with a recently diagnosed COVID-19 patient. So in these cases, definitely we tell the household members to again monitor their symptoms and to get themselves tested as per the norms. Neeraj, you want to add to that?
Yeah, so no, you have covered everything. So testing is definitely, if a person is asymptomatic of your household, you may wait, but that patient should be treated as a suspect case. He should not be mingling with us. But if somebody has symptom right away, then definitely he should get tested that day only. And in case if patient is symptomatic, then maybe he can wait for a couple of more days, and third or fourth day after that, one can get tested. But unless you test negative, you should not be stepping out of your house or interacting with other people. That should be the message.
Thank you to both of you. And another related question, if you could comment on the proportion of carers or other family members becoming infected from the patient undergoing the home-based care.
So if you take adequate care, because see, in India, what happens that we have a very close knit families where interaction is on daily basis, where you share items. So once somebody is infected, there was very little chance that the other members of the family are not infected. That is something which we have hardly seen. But yes, where the people were not infected and had opted for home-based care, we found that not many got infection because of that, because of taking, if they have been taking adequate care using the prescribed norms, they did not get infected, and other household members remained as non-infected. But yes, if we have caught infection right at the start, one person got infected earlier, the second person maybe a couple of days after that, because there is an incubation period where you can infect other without even realizing. That is the biggest problem, because 80% of the patients are going to remain asymptomatic, but they can definitely spread infection. But if they are not infected from the index case in the household, then after adequate precaution, most of them remained non-infected.
Okay, thank you. Thanks for that response.
So if I can add a little bit to that. So if you look at the secondary attack rate of, say, COVID-19, so what the data shows that, it can vary anywhere between 5% to 50%. It's a long spread, right? So as Neeraj rightly said, that, what we have noticed, though we do not have formal data from our state or from our center, but what we noticed was that, it was towards the higher side, that whenever a patient presented, the chances of the other household members being positive was pretty high, was pretty high. But it is very difficult to say that it's because of the home-based care. Once the home-based care is started, as Neeraj pointed out, if you are adhering to the norms and the basic tenets of home-based care, then the chance of infection isn't that much. So most probably these all infections, second infections, occurred before the home-based care was instituted.
Okay, and would you mind please commenting on, or could you perhaps give an estimate of the numbers of patients that were being managed at home during the peak of the second wave? And following on from that, how many patients can a health professional manage? And is this usually a nurse or a doctor?
So during second wave, it was like we were saying, the peak time 4 lakh new cases every day. So we can never provide so much hospital-based care for everyone. So if you ask me what was the exact number of patients which were provided home care-based management, that data is not with us. But from personal experience, I'm sure each one of us have at least guided more than 2,000 to 3,000 patients during that peak period for home isolation. So one patient means at least 2 to 3 members with their family. So you can very well understand. So exact data is not there, but majority of patients recovered at home, majority of patients. So if we had say 4 lakh cases per day, then of rough estimate could be 70 to 80% of those patients did not require hospitalization. They were managed at home, either because we have robust public and private doctors, basically team who could provide teleconsultation to majority of these patients. So exact number not there, but 70 to 80% patients were managed on home care based treatment.
So there was a second part to it as well, whether it's only the COVID physicians who can care for the patients, or can it be nurses as well? You want to answer that, Neeraj, as well?
So we had a protocol in place, and using that protocol, majority of patients could be managed at home. And so any person with some sort of medical training were able to provide that support because we had a robust training program as well, where you can say that people from AIMS took initiative and they trained healthcare professionals across the country, whether they were doctors, nursing staff, other ancillary support staff. They were trained how to provide the basic management part, how they can take care of the patient because of the magnitude of problem which we had to face. So it was job of not only doctors but other healthcare professionals as well to take care of these patients.
Thank you, Dr. Niraj. So you've spoken a little bit about availability of data with respect to home-based care. Do you have any outcome data in relation to home-based care outcomes at all?
So again, at that time, we are in process of publishing those data because we had a significant amount of patients who were managed at home. And offhand, I don't remember the exact data, but of those patients, around only 10% of patients eventually had to come to hospitalization situation. Rest of the 90% of patients could recover at home without any problem. So that is in under peer review right now, and that will be published soon.
Thank you. And what's been your experience with home-based care in small dwellings within India?
Could you repeat that question? Sorry, I couldn't hear that.
Of course. The question is, what was your experience with home-based care in small dwellings in India?
So again, like I said, we did train healthcare professionals across the country, whether it's a large city or a small district of the country or a rural setting. So we have provided support through teleconsultation, and all those cities and small towns or the rural areas did well, and they could tide over that particular situation when we had huge surge, especially in the months of April and May. So we have been doing well, but again, unfortunately, the data collection system in our setting is not that robust. So if you ask how many were successful or not, we can only, as an expert, we can tell you what happened at that time. And we feel that even in rural areas, with little bit of help from bigger centers, the cases were managed in a proper way, and most of those patients recovered in home care settings.
Dr. Animesh, would you like to comment?
No. I mean, I was just pondering over the use of the word dwelling. So does it mean rural versus urban, or does it mean small apartments, small houses, as compared to colony? I'm not sure about how you use it in your country.
So I think what the question might be referring to would be more the situation in slums, etc., where there's dense population, people together.
Yeah, I understand. So we have slums here. We have slums in other cities in India. Dharavi, for example, in Mumbai. So what we noticed there was that the infection control was very difficult over there, and the seroprevalence rate, which is actually reflects the rate of infection, either symptomatic or symptomatic, was actually the highest in the slum areas. Right. So in spite of our best efforts, I think the slum areas were the people where the most number of people, a large proportion of people got infected, right? But whether as far as mortality is concerned, those were higher as compared to the rest of the part of the city. There is no data to indicate that. So I think overall, the slums, they fared okay, though the proportion of infection, both symptomatic and asymptomatic, was higher in these slum areas.
Thank you.
Thank you. And we have a comment and a question as well within India. The comment is that many people in India were using fumigation, and the question is, does this help?
So fumigation, okay, Animesh, please.
Yeah, so I mean, so fumigation, I'm not sure whether fumigation was being used in homes as such. Neeraj, you would agree to that? I mean, fumigation was not being used at homes, but we have been using fumigation, say, in our endoscopy suite or in the bronchoscopy suites, right? So I hope by fumigation you're not referring to the steam inhalation. You're referring to the dispersion of chemicals inside a room for sterilization, right? Right. So those were actually not used very commonly, at least in Delhi, in homes as such. And as such, no regulatory authorities, CDC or WHO, they recommend the use of fumigation in dwellings. So they are mainly to be used in hospitals. And that also, that has to be coupled with other forms of disinfection and sterilization, like, contact cleaning and proper disposal of waste. And so, Neeraj, you would like to add to that?
Yeah, so that's what we mostly propagated that contact this thing disinfection. So all those surfaces which could be touched and used by other many more people, those were the parts which needs special attention in form of contact disinfection rather than using fumigation. So fumigation is usually used in hospital setting for sterilizing in any infected area, whether it's ICU or any isolation area. So for routine COVID-19 cases, we never recommended fumigation, just cleaning up the house and ensuring that it's well ventilated. These are the two strategies which we normally advise people in case if they had some household case for managing.
Okay, thank you. So Dr. Niraj, how did you work with the governing councils to organise biohazardous waste?
So to be very frank, I am not directly involved with that, but yes, here the municipal corporations, especially in places like Delhi, they had a well-placed system where in each colony they used to visit and collect the garbage from all those households which had cases, so that the chances of infection spreading from those household garbage is minimized. So we had a system in place where municipal corporation used to visit those colonies, especially those who were in lockdown, this thing or restricted areas, so that there is no difficulty in disposing of those garbage. So that was planned by the local authorities.
Thank you. And a few more questions. We've got some great questions in the chat. Have you used sotrovimab in home-based care?
So sotrovimab is still not available. Monoclonal antibodies still not being used in India. So none of the monoclonal. So we have used casirivimab and intesivimab combination. But again, this is not being used in a home-based setting. It is used in mainly in patients, mild COVID-19 patients who have risk categories. But all these patients are hospitalized first and then given monoclonal antibodies, and then then they are being discharged. So it is not, we are not using any monoclonal antibodies in the home setting.
And also, what impact did vaccination have on infection rates within the family during home-based care?
So one most important thing one has to remember that the primary role of vaccination is to ensure that you don't get a severe form of disease. And so the vaccine may actually not prevent you from getting that infection. So infection and disease are two different aspects. Infection is just presence of that particular pathogen in your body. But once it starts manifesting in form of some symptoms, then it's called disease. So the primary role of vaccination is just to prevent you from getting severe disease. So whether it's going to prevent that household infection, in case if you are taking care of your somebody in your house, is something which we have to, which we don't have enough data to prove. That's why, in spite of vaccination, we have been promoting this what we call as social vaccination, that is use of social distance, physical distancing, the masking, the hand hygiene. So even if you are vaccinated and you have to take care of somebody at home, please do follow this principle of social vaccination to keep yourself safe.
Okay, and thank you. Following on from the previous question is, what about steroids? And did you administer steroids in home-based settings at all?
Yeah, so if I can answer that question. So, as such, so none of the drugs commonly used, like say antivirals, remdesivir, steroids, or anticoagulants, they are supposed to be used on an outpatient setting or in a home-based care, right? So that is what the guidelines say, and we have been adhering to it. But however, that the second wave around April 2021, it so happened that within a short span of time, hundreds of thousands of people were infected, and these people they require oxygen. Some of them, a large proportion of them, they were also using oxygen at home. So they were actually patients who deserve to be in an institution, but due to the fact that there were so many cases, they could not be accommodated in the hospitals. So these patients were severe COVID-19 patients being managed at home. So in this setting, we had used steroids, and the doses have been used for hospitalized COVID-19 patients, right? So under extraordinary circumstances, we have been forced to use. Do we recommend that to be used otherwise? No. Are we using it now when things are under control? No. So any patient who is having oxygen less than 94%, supposed to get steroids, he needs to be admitted first, administered oxygen, administered anticoagulants, administered steroids. But this should happen in a hospitalized setting.
Thank you for that, Doctor.
Yeah, so just to add to that, yeah, so definitely somehow the message went across that steroid is treatment for COVID-19. And that's why people start taking it right at the start of disease, even when they were isolating at home. So this message should be clear that steroid is not a treatment for COVID-19 infection per se. It only should be used when the patient develops complication in form of uncontrolled inflammatory response against this particular disease. That is when patient develop desaturation, the oxygen levels comes down, and other complications start happening. And in that situation, the patient should be in hospital, not should be managed at home. So that's why we never recommend steroid at home. But yes, during that particular extraordinary situation where sometimes we had to take a call that patient could be monitored at home, we could provide oxygen support there, then only we considered giving them steroid at home or anticoagulation. So all these treatment for COVID-19 should not be tried at home.
Of course. Thank you for clarifying, both of you. And thank you for answering all of our questions this evening. We have one last question, which is, what general investigations do you perform in patients and at what frequency?
Dr. Nimesh?
Yeah, so if you're talking about patients who are being managed at home, so WHO and CDC says that these patients, they should not routinely undergo any investigations, right? So normally, I personally do not prefer suggesting investigations for these patients who are being cared at home. But however, sometimes there is some concern on the part of the person who is being managed at home. So in these cases, what I do is that I generally screen the routine investigations like a complete blood count, a kidney function test, liver function test, and a CRP, say by day 5 at the end of first week of symptom. So it is, again, I would like to reiterate, not for my understanding, because I'm very happy if the patient is reporting any new symptom, his saturation, his pulse rate, etc. fine, and his as I said, his SpO2 is doing fine. So I'm very happy clinically monitoring the patient, but sometimes in such circumstances, I would suggest these investigations to be done by the end of first week of symptom. Neeraj, you would agree with that? Do you?
Yes, I will definitely agree with that. Routinely, for patients who are mild and we have advised home-based care, usually they won't be require any sort of specific test. Once the patient starts showing worsening of symptoms, that is when they should be in hospital where relevant tests can be done. So in the start of disease, there is no specific test which can predict that this patient is going to dip or show deterioration in their symptoms. And that's why, like any other viral illness, these patients, most of them, if in home isolation, will not require any specific test. And if they are worsening, then they have to be in hospital, and all test and whatever investigation we want to carry out should be carried out in hospital settings.
Well, thank you, Dr. Niraj and Dr. Animesh. Thank you for answering all of those questions, and thank you for your fantastic talk this evening as well, Dr. Niraj.
All right, thanks. Thank you, Bridget, for hosting the Q&A session. And thank you to our wonderful presenters. Once again, it's been a very informative session, and I'm sure that many of us around the world will be able to apply those principles in reducing the burden to hospitals. So I just wanted to give a plug on our webinar next week, which is Wednesday, the 20th of October, same time. This will be delivered by Dr. Jason Agostino, and the webinar is on Aboriginal and Torres Strait Islander peoples and COVID-19, where we'll be talking about the two strains, so the initial COVID-19 strain as well as the Delta strain. Now, many of us will recognize Dr. Agostino. He is not only part of the ANU medical school, but is also an epidemiologist and an advocate working part of the Aboriginal and Torres Strait Islander peoples National Aboriginal Community Controlled Health Organization. So the talk will be on the leadership of Aboriginal and Torres Strait Islander people and the steps that are taken to protect these communities, challenges in vaccine rollout, and what needs to be further done to protect these communities as Australia is opening up its borders. So it'll be a very, very interesting talk. And for any of us who are interested and know of anyone that's interested, please circulate this to your contacts, and I'll invite us to register using our website. So that's it from us. Thanks to our audience again for tuning in tonight. And I just want to reiterate, so we have the ANU COVID-19 Peer Support Program. If you want to find out more about us, please visit our website. Importantly, if you are a medical or healthcare professional who wish to volunteer, I'll invite you to email us as well, and we'll get in contact with you. Thank you so much for tonight, and I hope you have a safe rest of the day.